Okay, thank you so much. This is Mulat from Ethiopia. I'm helping the Ethiopian hepatitis birth dose pilot implementation. I'm going to present the Ethiopia's initial experience on hepatitis B birth dose pilot implementation. So this is the country statistics. Ethiopia have around more 103 million. This country is the second big country in Ethiopia. In Africa, estimated live births is around 3.5 and estimated surviving infants are around 3.3. The proportion of the skilled births are 50%. It ranges from 26 in Somalia region within Ethiopia and to 96% in Addis Ababa city. This is the biggest city in Ethiopia. The country, with regard to the country prevalence, hepatitis B prevalence, the estimated prevalence among the general population is around 3.4, estimated 7.4, and the estimated prevalence among the pregnant women is 4.7, and the estimated prevalence among the children under 5 is around 4.4. So this shows that Ethiopia is considered to have intermediate to high hepatitis birth dose infection prevalence. So this is the distribution of hepatitis infection among regions. This is in all regions. We can see that it is the burden is very highest. Even the pentavalent vaccination coverage is low in the regions with the highest hepatitis B virus infection. So with regard to the preparations before the pilot implementation, we were included in our strategic plans. It was indicated to be introduced in 2080, but it was not realized. But since 2017, the Ethiopian National Technical Advisor Group initiated discussions on the national hepatitis birth introduction, and then additional evidence were received from research advisor group. They come up with, as it is feasible, the economic evaluation was as the incremental cost effectiveness ratio was very indicated it was very cost effective to introduce. Following those couple of evidences, the country, along with the stakeholders, had discussed and developed a policy brief and concept notes, and then proceeded to the implementations. These were the basic objectives that we were already set. The first objective was to identify and address the programmatic and logistical barriers. Secondly, it is both to draw lessons and learn it and document best experiences, and now determine the acceptance of the vaccination by healthcare workers, and then to estimate the uptake and coverage level, and then to determine the impact and effectiveness of the pilot implementation, and then finally cost and cost effectiveness components will be determined after implementation. So this is the method of the piloting that was already set. The design, because this is a new design, the country is planning to vaccinate these newborns in the delivery rooms. So all the delivery sites, as well as all the tasks and vaccine logistics, the training component, or the linkage issue is linked with the staff in the delivery and the postnatal and NICU vaccination rooms. So this is a new vaccination site for us. So the country is expecting to have a great integration and coordination among maternal, child, and vaccination services. The setting, all the settings in the country, the urban settings, the agrarian and pastoral settings included, the hospital, health center, and health post, all the type of health facilities in the country is included on the pilot. So this is the basic indicators that were used to select the 4 districts from the 4 regions in the country, specifically the antenatal care coverage, the postnatal care coverage, the seroprevalence level of the regions were considered to select the 4 districts in the country. So with regard to the other information related to the introduction, the reporting, recording, and training materials and the IEC information education materials were prepared properly and shared with the people who are working in the pilot implementation and the admin levels that are following this pilot implementation. With regard to the results that we have seen for the last 5 months, it is very promising. Around 5,864 newborns had get the hepatitis birth dose vaccination. Of this, around in all menses, across all menses, more than 97, 98% of the newborns are getting the vaccination on timely fashion. When we operationally we had defined the timely is if the newborn is got with 24 hours, but if it is defined late, if the newborn have got the vaccination service beyond 24 hours up to 14 days. So with regard to the monitoring and evaluation documentations, the focal points are identified from all the sites, supervisions, review meetings, as well as sharing the lessons that we have gained so far to other countries, the reporting, standardizing the reporting templates and sharing for the pilot sites are part of the monitoring and evaluation documentation. So we have developing on evaluation proposal at the end of the pilot implementation. This is the work on progress. With regard to the challenges that we have faced so far, the place of birth is one of the determinant factors. The low facility delivery and high home delivery are one of the factors, as we all know. Socio-cultural factors. For example, in Ethiopia, if mothers born at home, they will stay 45 days at home without visiting the health facility. This is the biggest challenge for us. So the additional costs, because the whole service is shifting from the immunization room to the delivery room or new neonatal intensive care units and postnatal care services. So the time factor, because we are intending to provide the service within 24 hours. So this is an ideal recommendation to add here, but it is, as we have noted, that there are newborns who are getting the service late, beyond 24 hours. This is a new strategy and implementation modality. So it is a bit tough to manage. So this is all, I think, with my presentation. So thank you so much.